All right, let's get right into it. Today, we are taking a deep dive into one of microbiology's most challenging adversaries, Neisseria gonorrhoeae. This is a pathogen that has been outsmarting our therapies for decades, and really, understanding its entire playbook from the lab bench to the clinic has never been more critical.
And to really get a sense of the scale here, we're talking about an estimated 82.4 million new cases in adults every single year. That officially makes gonorrhea the second most common bacterial STI on the entire planet. It's just a massive public health issue.
Now, just a quick note before we jump in. This whole explainer was put together using Gemini Deep Search, which helped us pull and synthesize all the latest research. And for any of you who want to dig even deeper, a full list of all our sources is available in the accompanying notebook document. Okay, so here's our game plan. We'll kick things off with its clinical significance, then we'll get into detection, the classic gram stain versus our modern molecular methods. We'll cover the tricky business of actually culturing this thing, then we'll decode its incredible resistance mechanisms, look at the split in global treatment strategies, and wrap it all up with the public health battlefront. So, first up, the global threat. And here's the most important thing to remember. Unlike its many commensal cousins that just hang out harmlessly in our respiratory tract, when you find Neisseria gonorrhoeae in a clinical sample, it is always significant. There's no such thing as a colonizer with this bug. So here's its formal address in the microbial world, first described by Albert Neisser, way back in 1879. Now, while it belongs to the pretty big Neisseriaceae family, which is full of mostly harmless bacteria, it's really itself and its cousin, Neisseria meningitidis, that are the two main pathogens of the group. And the disease it causes has an incredibly broad spectrum. It can be a totally silent, asymptomatic infection, which, by the way, is a huge driver of transmission, especially in women. But if it goes untreated, it can lead to devastating pelvic inflammatory disease, causing infertility, or even spread through the bloodstream, causing things like septic arthritis or endocarditis. Okay, so a specimen hits the lab. What's the very first thing we do? Let's look at how we start to unmask this pathogen, comparing the old school smear with the new school signal. For anyone who's spent some quality time at a microscope, this is an iconic image, right? That path of mnemonic sign, those little pink, kidney bean-shaped diplococci, all huddled up inside the very neutrophils that were supposed to destroy them. It's a classic clue, especially from a urethral discharge in a symptomatic male. But, the gram stain definitely has its limits. In symptomatic men, it's fantastic. But for cervical or asymptomatic cases, its sensitivity just plummets. That's where NAATs, or nucleic acid amplification tests, come in. They are way better for screening because they're incredibly sensitive and they don't need live bugs. But, and this is the absolute key, they can't give you an isolate for antimicrobial susceptibility testing. And that is exactly why culture is still completely essential in our fight against resistance. Which brings us perfectly to our next section, the challenge of actually getting this thing to grow. Neisseria gonorrhoeae is notoriously picky. It's a truly fastidious foe. It demands a very specific environment. You need that CO2-enriched atmosphere, a super precise temperature of 35 to 37 degrees. It absolutely hates the cold, and it just won't grow on standard blood agar. It needs the rich nutrients from chocolate agar. And then, to isolate it from non-sterile sites, you have to use a selective media, like modified Thayer Martin, which is basically laced with antibiotics to kill off all that competing background flora. And once you do get it to grow, the colonies themselves actually tell a story. This is a perfect illustration of phase variation. The small, glistening T1 and T2 colonies, that's the virulent form, covered in pili that help it attach to our cells. But after a few subcultures in the lab, they often switch to the larger, flatter T3 and T4 forms, losing their pili because, well, they just don't need them anymore. It's a direct visual of a key virulence factor being switched on and off. So once we have an isolate, we have to confirm its identity and, most importantly, understand its resistance playbook. This is really where we confront the single biggest challenge with Neisseria gonorrhoeae. Okay, so the crucial test here is the carbohydrate panel. All pathogenic Neisseria are oxidase positive, but what sets Neisseria gonorrhoeae apart is its metabolism. It utilizes glucose and only glucose. Neisseria meningitidis uses both glucose and maltose, and the harmless commensal Neisseria lactomica uses all three. This simple biochemical pattern is a cornerstone of its identification. Now, this is where it gets really fascinating. How does it build resistance to our last-line drugs? Well, it's a master of genetic theft.
It literally picks up DNA from its harmless commensal cousins that are living in the throat. It then stitches these foreign DNA fragments into its own PenA-B gene, creating what we call a mosaic version. This mosaic gene then produces an altered penicillin-binding protein 2 that ceftriaxone just can't bind to effectively. You add in some mutations to pump the antibiotic out and block its entry, and you've got yourself a superbug. So this rampant resistance has led us to a pretty major strategic dilemma. How do we treat this infection and at the same time preserve our last effective antibiotics? This has created a really interesting schism in global guidelines. This table really lays out the two competing philosophies. On one hand, you have the US CDC and WHO, who have doubled down on high-dose ceftriaxone monotherapy. They've pretty much abandoned azithromycin because of resistance. On the other hand, the European IUSTI guidelines still recommends dual therapy. The idea there isn't so much about treating chlamydia, it's about using azithromycin as a shield to protect ceftriaxone, based on the principle that it's harder for the bug to develop resistance to two drugs at once. And when we look at the susceptibility breakpoints, there's another critical detail to notice. For ceftriaxone, EUCAST doesn't use a traditional clinical breakpoint. Instead, they use an epidemiological cutoff, or an eco-off. What this means is that any isolate with an MIC above the wild-type population gets flagged. It's a super sensitive early warning system designed to detect what we call MIC creep, that slow rise in resistance, long before we start seeing widespread clinical failures. Now, treatment in pediatric populations follows similar principles. It's mostly weight-based ceftriaxone dosing, but it is absolutely vital to remember the quote on this slide. A diagnosis of gonorrhea in a prepubertal child is a massive red flag for sexual abuse and requires an immediate and thorough safeguarding response. So, with all that in mind, how do we fight back on a larger scale? Well, our final section covers the public health strategies that are just essential for controlling the spread of resistant Neisseria gonorrhea. The strategy really has multiple prongs. Aggressive screening is key, especially 3-site screening. That's urethral, rectal, and pharyngeal for high-risk populations. Prompt partner notification is crucial to break those transmission chains. A test of cure is mandatory for all pharyngeal infections, since they're tougher to clear. And because reinfection is so common, retesting all patients at 3 months is just standard practice. And finally, any suspected treatment failure has to be reported immediately. We really hope you found this explainer useful. If you're enjoying these deep dives into the microbial world, please consider subscribing to the channel. And we genuinely want to hear from you. Leave your questions, your feedback, anything in the comments. Let's get a good discussion going. So I'll leave you with this one final thought. We are really on the edge of losing our last effective drugs against gonorrhea. The most promising path forward might actually lie with its cousin. Could the antigenic similarities with Neisseria meningitis, which we've seen offer some cross-protection, finally be the key to developing a long-awaited and desperately needed vaccine? It's the question that's going to define the next chapter in our fight against this incredibly resilient pathogen.